Dr. Vimala, Dr. Himanshu and Dr. Vimala, good evening to all. Can you see me and hear me? Any one of you, can you please respond? Okay, thank you very much. Let's talk about a couple of case scenarios and the mechanisms of chest pain in children today. Probably this is important from the practitioner point of view rather than the exam point of view. In the exam, most probably we will be getting cases of either cyanotic congenital heart disease, acyanotic congenital heart disease with heart failure, or various spectrum. But by and large, chest pain is a symptom which is seen in most of the variety of the conditions, right from the problem on the skin to the internal myocardium and endocardium. So let us see a couple of the things which we are going to talk today. Chest pain in children, predominantly it is due to non-cardiac causes. Cardiac causes is not the commonest one. Non-cardiac causes are the commonest one, predominantly either due to chest wall muscle causes or pulmonary causes. These are the commonest causes for the chest pain. So, coming to the chest wall causes, trauma. Most of the children who go to school, they carry a lot of baggages, books, boxes, and that can cause some kind of muscular chest pain also. So this is one of the commonest problem which I regularly see in my practice, that parents come that my child is having a chest pain showing me. Upon taking the history, that child will be carrying a lot of weight from home to school. So other causes like a costochondritis, usually it is seen in case of adolescent people where the pubertal growth spurt is seen. Hormones can cause more of the inflammatory reaction at the costochondral junction. Pericardial catch, that may be due to muscle catch, that may be due to pleuritic catch, so many things. Then infection, mastalgia, and herpes zoster, which we don't see regularly in our country. Coming to the pulmonary causes, I am sure that you are all aware that asthma is one of the commonest conditions where a child usually will tell that baby is having some kind of tightness in the chest or breathing difficulty or kind of wheeze. And other conditions like pneumonia, early part of the pneumonia will have inflammation of the pleura and pericardium. Suppose you have left-sided pneumonia, left-sided pleurisy, you will have chest pain, and usually it is you will see exaggerated during the time of inspiration. That's why there will be some restriction of the chest movements on that particular side, and the baby will tell that when you take a deep breathing and the coughing, there will be pain will be exaggerated. So pulmonary embolism is a very, very rare cause in children unless they are having DVT or malignancy or some kind of other hyperviscosity in situ thrombosis and all. Otherwise, generally we don't consider that as a cause for chest pain in children. Other conditions like a gastroesophageal reflux disease, especially weekends when you have spicy, oily food and gastritis is there, then they get a kind of chest pain. So these are all various kinds of chest pain, and the psychogenic cause is the commonest one among all, one of the commonest, especially school-going children where they get a kind of chest pain. So this includes the lungs, ribs, chest wall, muscles, diaphragm due to either injury, infection or irritation, whatever it is causing the chest pain. Coming to the chest pain of cardiac causes may be due to either coronary problem or myocardial or pericardial problem or valvular problem. So basically you divide into three major categories. I am just telling, it's not given any books or anything. Group 1 causes are coronary causes, group 2 causes are the myocardial, pericardial causes, group 3 causes are the valvular causes. But of all commonest is going to be myo and pericardial causes. But from the point of interest, coronary causes should be elaborated and discussed first, because it's treatable and immediate attention is very, very important. Coronary causes may be due to congenital coronary abnormalities or acquired coronary problems. So you have various abnormalities. Congenital coronary abnormalities means it's a coronary AV fistula or myocardial bridges or abnormal course of the coronary between aorta and the pulmonary artery, or an acquired coronary causes like any familial hyperlipidemia syndrome, which can produce the atheromatous plaque at the osteo of the coronary, causing the flow abnormality, or post-Kawasaki disease where persistent coronary aneurysms are there, then thrombus formation will be there. Or whatever the underlying mechanism, whenever there is a flow to the myocardium during diastole reduces, then also you will get the chest pain. So these are all various coronary causes. Whereas coming to the myocardial causes, like you have myocarditis, pericarditis, myopericarditis, all these whether direct or some other indirect evidence also will cause some kind of problem. Valvular we will discuss, that is because the fixed obstruction will get a problem. So in children, the symptoms are age specific and cannot be expressed by all age groups. For an example, I am telling you, there is a near infant, baby has got a problem and is having a chest pain. So infant cannot tell that baby is having a chest pain. So what baby will do? Excessive crying, fussiness, irritability, and unexplained crying will be there. So these are all a vague indirect symptoms which a physician should build up the story and then should understand that this baby probably is having chest pain. The sensible way of telling the symptoms usually will be after 7 years of age. So whenever you are taking history, if you want to take that this is the definitive history of chest pain, child should have minimum of 7 years. Between 3 to 7 years of age, they will tell vaguely that they have problem here, that may be chest pain, that may be discomfort, dyspnea, or that may be palpitation. So it may be chest pain, you will get some idea, but you are not sure that it is going to be chest pain. So what I am trying to tell you is symptoms are age specific and cannot be expressed by all age groups. You have to come to an understanding that this child may be having chest pain at the end of the day. So let us see some of the case examples today. You can see 14 years old girl referred for evaluation of chest pain at rest and palpitation. The chest pain is catching discomfort and present on lying left lateral position. The child is having a thin build, normal pulse and blood pressure. On examination, there is a non-ejection click, 2/6 systolic murmur, and respiratory system is normal. By doing dynamic auscultation from standing to sitting and sitting to standing, the murmur is becoming more obvious. So I want to ask you, what is your diagnosis at this juncture? So can you guess what the diagnosis? A thin build girl, 14 years, history of chest pain, discomfort. So Dr. Vimala is telling mitral valve prolapse. Absolutely perfect. You have to consider mitral valve prolapse. There is a non-ejection click, there is a systolic murmur, and the murmur is becoming the most obvious when child stands up and all. So LV becomes empty. So what is the mechanism for chest pain in case of MVP? What is the mechanism? Why they develop chest pain? So this is the echocardiogram. You can see what is the echocardiogram diagnosis of this baby. This child, same child came with the chest pain. We have to examine, and you can see the echocardiogram. What is the echocardiogram? So Dr. Himanshu, what you have written is correct. This is again the parasternal long axis view. You can see there is a significant mitral valve prolapse with a mild to probably moderate regurgitation. It's an eccentric jet. So you can see this. So I am just going to ask you, what is the mechanism of chest pain in MVP? So there are a lot of hypotheses. Actually, nobody knows why the chest pain comes in these kind of cases. One is, as you said, papillary muscle ischemia. Second is, if you look at this mitral valve prolapse, the mitral valve is redundant. The chordae is very much lengthened. So what will happen? The papillary muscles and the chordae are floppy and will prolapse into LA, which causes some kind of a traction and stretch on the papillary muscles and the chordae. That is probably one of the mechanisms people thought that that's the reason for the chest pain. So one of the commonest cardiac problem which they come to you, young girls, usually chest pain is due to mitral valve collapse. What are you going to give her treatment? What is the treatment which you offer in this particular situation, guys? So first we need to counsel the family, reassurance, then probably beta blockers will help. Beta blockers, how they help? It's a different mechanism. One is the cardiac cycle diastole will be increased, heart rate will come down, and preload will be increased a little bit, and so that LV will be voluminous and mitral valve prolapse will come down. So that the stress on the muscles, papillary muscles and the chordae will come down. So beta blockers play major role in case of chest pain of mitral valve collapse. So let us look at the second case. This is a 16-year-old boy, tall boy, with occasional chest pain while playing. Mother is myopic, -10 and tall. He underwent eye evaluation because he also had got problem, and they found that there is a subluxation of the lens and requested cardiac clearance for the surgery. The examination showed normal pulse and blood pressure and normal heart sounds and no murmurs. So by this time you all must be knowing the diagnosis. Tell me, what is the diagnosis? Absolutely correct. You have to think about Marfan syndrome here because he is tall, and we know how we evaluate Marfan syndrome under. But my question to you is not that. Now you tell, how do you follow the case of Marfan syndrome, and what are the things which you want to do by echocardiogram? Yes. So you have to see that there are any chronic dissections or acute dissections in this adolescent group, and you have to take the measurements, absolute measurements of the body surface area. Especially you can see that this is the annular measurement, then the aortic annulus measurement, and you can see the sinus of valsola measurement. It's a little bit lower down, but I have taken here sinotubular junction and ascending aortic measurement. So any measurement which goes more than +2 is going to be very dangerous. So this particular boy, you can see the dilatation is quite significant. It is 3.8, which is coming for his body surface area, or people calculated, which is going to be +3.5 or something. So it is important to plot the aortic dimensions on a graph and serially follow them is very important. So whenever the dilatation reaches or sinus of valsola dimension goes up beyond the point of which is described, they have to undergo elective surgery, either aortic replacement or either Bental procedure if there is a valvular regurgitation, or root replacement should be done in these particular cases. So the evaluation essentially constitutes, take the arm span, which should be more than the height, and you all know that the thumb sign and wrist sign, all those things will be there, wrist sign, and eye examination is very important, and serial echocardiograms are very important, and CT scan or MRI is going to be very useful to see the annulo-aortic ectasia and ascending aortic dilatation in these individuals. and to see the chronic dissections and all. So elective surgery is preferred in this particular kind of patient. So generally you will see 50% will have aortic root dilatation in 10 years time, and by the time they reach 20 years, most of the people will have significant aortic dilatation and they need to undergo surgery. So Marfan syndrome is one of the important conditions. They can have acute chest pain or chronic vague chest pain, and you need to assess it thoroughly clinically in this kind of people. So let us see the other thing. Case number 3. This is a 6-year-old girl presented with vague chest discomfort and pricking pain. There is a history of, there is an examination, there is a tachycardia of 120 beats, blood pressure is normal, normal heart sound and no murmur. ECG is showing non-specific changes. So I will tell you, past history, she had probably, I will show you the echocardiogram and then we will decide. So this echo was done at PGI Chandigarh. It happened that I have to conduct a workshop recently in PGI Chandigarh, and thanks to Dr. Rohit Manoj, he contributed this echo picture. You can see this is the aorta, this is the pulmonary artery, and left coronary artery. You can see here there is a thrombus here. There is a thrombus. So historically, this child had rash, fever, and she received gamma globulin 6 months back. So fantastic. Your diagnosis of Kawasaki disease is very, very good. So I want to know from you, in Kawasaki disease, how do you follow the child and what are the medications based on the coronary artery size you give? So if there are coronary aneurysms, we have to give lifelong antiplatelet medications. If there are giant coronary aneurysms, by definition, more than 8 millimeters in most of the studies, or more than 10 millimeters, you have to give oral anticoagulant. Fantastic answers I am taking today. So aspirin you have to give 2 to 5 milligrams per kilogram, or dual antiplatelet medications 1 to 2 milligrams per kilogram, or oral anticoagulant. So this is the left main up to here, then LAD saccular aneurysm and thrombus is coming here, and I think this child should need oral anticoagulants for long time. So see this picture, this is another child presented with mild vague fever and acute gastroenteritis in a 4-month baby. If you look at this, this aorta, this is the pulmonary artery, this is aorta, this is what the coronary artery, left coronary artery, hugely grossly dilated. So my question to you, what are the risk factors for the coronary artery aneurysms? What are the risk factors? Giant coronary aneurysm. Very good. Male, younger the baby, small baby, and the constitutional symptoms like gastroenteritis and thrombocytosis, which is very high, and all you can read, lot of things are there. These are the important criteria you have to read in Kawasaki disease. So when you see such kind of giant aneurysms, and some patients, those who receive steroids also, they get this kind of thing, or those who are not responding to the gamma globulin therapy, then sometimes you have to give methylprednisolone. Very good. So giant aneurysms are seen in case of certain category of the high risk people, and you should identify and you should give gamma globulin maybe 2 doses. 2 means a repeated second dose in those conditions if the fever is persisting and all. So my question to you is, what do you give when there is refractory KD? Refractory KD means a child with Kawasaki disease not responded to first course of immunoglobulins. What do you give? What is your next line of modality? I want to know answer this. So repeat gamma globulin is the first one. Fantastic, fantastic. Repeat gamma globulin is the first one. Second, gamma globulin plus methylprednisolone. Third, apixaban. Very, very good. I think monoclonal antibody should be given. Our experience, we have given so far in 2 kids with the monoclonal antibodies. One is refractory case, second is allergic to the gamma globulin. Okay, very good. I'm enjoying your answers actually. So acute and subacute myocarditis, pericarditis, mitral aortic insufficiency, arrhythmias, and coronary aneurysms are seen in 20 to 25% of the patients, and 5% of patients if treated even with gamma globulin, you will see that, and usually they appear on the end of the first week to the 4th week after onset of fever. And IV gamma globulin is the modality of treatment. And if you follow these 20 to 25% of the coronary aneurysms, 49%, nearly 50% they regress, 90% they develop, 19% they may develop stenosis, and some of the patients they may develop a myocardial infarction during the course of this aneurysm. So those who are having aneurysms, it's a must to give oral antiplatelets or anticoagulants based on the type of the aneurysm and the size of the aneurysm. So let us go to the causes for the myocardial ischemia in children. Other things are congenital anomalous coronary arteries, anomalous origin of left coronary artery from pulmonary artery, and anomalous origin of the incorrect sinus of Valsalva. That means you are arising from the coronary with the vex and all will be there, or course of the coronary artery between the pulmonary artery and aorta will be there. That I will discuss a little bit later on. Let's go to some other case. So this is a 12-year-old girl developed chest pain while playing basketball. This is a real story. She developed palpitations and syncope immediately. She was unconscious. Mother called me actually. She was unconscious and shifted. I asked them to shift to the nearest hospital. Mother said there is no pulse, and she started resuscitating, and there was immediate hospital, and she was resuscitated. However, could not be revived. Baby died actually. So they did. Baby survived for 2 hours after resuscitation. They did an echocardiogram also. Historically, what happened? She underwent a balloon dilatation of the aortic valve during infancy, and subsequently, under follow-up with the cardiologist, she was advised to re-balloon aortic valvotomy, but she did not undergo. So, what is your diagnosis in this? So, diagnosis is obvious. This is restenosis, aortic valve stenosis, recurrence happened. But why should a child develop chest pain in aortic stenosis? I want to know the causes for chest pain in coronary artery disease, aortic stenosis. So what are the causes of chest pain in case of severe aortic stenosis? Okay, there's a systolic strain, very good. So there's a mismatch to the demand versus supply. So in aortic stenosis, there will be left ventricular hypertrophy, and you expect that filling of the coronary should be adequate to the myocardium. But whenever there is a ventricular hypertrophy, the amount of blood to the myocardium may not be sufficient. So they develop exercise-induced chest pain because the demand versus the supply is very less. Very good answer. Second, they may develop myocardial bridges. Some bridges may be there, or coronary artery may be compressed during a systole also, they get chest pain. Whereas in case of adults, commonest cause apart from this is you have accelerated atherosclerosis or coronary artery disease is seen in case of this. Whereas chest pain in aortic stenosis with LV dysfunction, what will happen? In case of aortic stenosis with LV dysfunction, your ventricular end-diastolic pressure will be raised. So LV EDP will be raised, whereas the coronary driving pressure will become narrow. That means your diastolic filling pressure versus LV EDP difference will be very much less, so that the amount of filling will be very less. This is usually happens in case of aortic regurgitation rather than aortic stenosis. What will happen in case of aortic regurgitation? The diastolic pressures will fall significantly low, very less, whereas LVEDP is going to be very high. So again, the coronary filling pressure, driving pressures will become very, very less, and they develop a nocturnal angina because during night time there will be fall in the heart rate, diastolic will be increased in case of aortic regurgitation. So chest pain in aortic stenosis is a very, very important symptom, and if they develop chest pain, that means you all should read the timetable of the symptoms in case of aortic stenosis: chest pain, dyspnea, and syncope. So these are the three most important dangerous symptoms in case of aortic stenosis. You have to act very, very aggressively in these cases. So 13-year-old boy with occasional chest pain while playing, on examination normal heart sound, there is an ejection clip and a 3/6 ejection systolic murmur present, and respiratory system is normal. So you can see that there is a left ventricular hypertrophy here, and what are you seeing here? You can see there that the aortic wall there is a abnormal, it's a functional bicuspid aortic wall. So this is again an example of aortic stenosis where LVH demand versus mismatch will be there. So this is a child who actually we retrieved the ECG of that particular baby who came for follow-up sometime back, and you can see significantly LVH here, very, very significantly LVH here, and no wonder that there will be significant demand versus mismatch and hypertrophic organ chest pain in this kind of patient. So this is an young adult with shortness of breath and chest pain, and on examination there is an ejection clip and 4/6 ejection systolic murmur present. So we have taken ECG. You can see the ECG here. So what is the ECG abnormality which is shown here in the presence of chest pain of an adolescent to young adults? So very good. There is an ejection clip and ECG showing RVH, very good. You can see the PR interval, this is the sinus rhythm, PR interval is normal, and there is a right axis deviation and monophasic or in, there is no monophasic or, but RVH is seen as evidenced by tall RVH in V1 and significant deep SVH in V5 and V6 suggests that it is severe RVH in the presence of ejection clip and 4/6 ejection systolic murmur. We will come to a diagnosis of pulmonary stenosis. This is very, very clear. I want to know why they develop chest pain in PA. Nearly 10% of the individuals with severe pulmonary stenosis, they develop chest pain. That is because of the RV ischemia, RV angina. Again, the same basic principle plays here. The demand versus supply. The right ventricle is hypertrophic, and the supply from the right coronary artery to the right ventricular myocardium may be significantly less whenever the child is playing because of the fixed cardiac output. The cardiac output may not be maintained, and the coronary filling pressures also may be same amount for the degree of obstruction. Because of the RVH, myocardial perfusion on the right side may be less. So that's why they develop chest pain in 10% of the individuals. So what do you take when you clinically suspect a child with pulmonary stenosis? Would you like to take X-ray or would you like to take ECG? What is your choice of investigation? Yes, absolutely correct. ECG will give lot of clues to tell that there is a hypertrophy, whereas X-ray will tell you the clues of dilatation. So whenever there is dilatation of the chamber or increased vascularity, you have to advise X-ray. Whenever there is hypertrophy of the chamber, you have to take ECG. So here you can see the chest X-ray, which is quite normal cardiothoracic ratio, except that the left pulmonary artery dilatation is essentially normal. So the left pulmonary artery dilatation in the critical valve, severe valvular PS, because of the valve is quite doming, eccentric, the jet will go preferentially into the left pulmonary artery, hence you will get this kind of left pulmonary artery dilatation. So that is the mechanism why you see that, but however you need to take ECG rather than X-ray in this particular scenario. So let us move on to the other example. Unfortunately, I kept case 5 as a hypertrophic cardiomyopathy, but that got deleted. That's why I am just going. One of the cause for the chest pain is hypertrophic cardiomyopathy, either obstructive or non-obstructive. So hypertrophic cardiomyopathy in infant is due to one of the main causes Pompe's disease, which you should remember. But they may not tell that they have angina and all. Similarly, in case of adult children, adults, and familial hypertrophic obstructive cardiomyopathy is seen, or non-familial will be seen. Non-familial may be due to Noonan syndrome also. Noonan syndrome is one of the causes where you will see the hypertrophic cardiomyopathy. So in these children, again, the same LVH is there, and myocardial bridges also will be seen. Those can cause a systolic compression on the coronary artery. So these are some of the mechanisms of chest pain in case of hypertrophic cardiomyopathy. I would like to move to the next case. He is a 14-year-old boy, came with chest pain to our ICU, sweating and fever. There is a tachycardia, low volume pulse and LVS. So obviously you are going to tell it's a diagnosis of, absolutely, it may be pericarditis or myocarditis or myopericarditis. Absolutely correct. I do agree with that, because there is a tachycardia, there is a low volume pulse, there is a LVS3 and myocarditis is possible. So what do you take? We can do echocardiogram. Suppose we are taking ECG. So is it consistent with myocarditis? Can you tell, is it consistent with myocarditis, this ECG? The same ECG from that one. So I want to know what are the clinical criteria to suggest this is a myocarditis based on the ECG. So you all can see that this ECG is showing, number one, low voltages, fantastic. Then the voltages are lesser than 5 millimeters in the standard lead or lesser than 10 millimeters in the precardial lead, that is called as low voltages. So you can see that the tachycardia and low voltages are suggestive of this is consistent with myocarditis. So what we see in the echocardiogram in these children, usually the left ventricle will be dilated, thinned out, and there will be severe dysfunction and there may be regurgitation. Would you like to see X-ray of the echo of this baby? Sorry for that. So you can see the echo. So I want to ask you, is it consistent with myocarditis? Is it consistent with myocarditis? See here, it is actually pericarditis. You can see the myocardial mass is preserved. There is a rather left ventricular hypertrophy. You can see the postal wall thickened. Myocardial function is a little bit less. It is not that drastically it is down, and there is no thinning of the myocardium. But if you look at that pericardium, there is a pericardial effusion. So its echo is not suggestive of myocarditis. Echo is suggestive of it's a pericarditis on the top of some kind of left ventricular hypertrophy. Most probably this child might have received inotrope, an aggressive inotrope, which causes some kind of spurious LVH, or on the top of some kind of left ventricular hypertrophy, child might have developed myocarditis. So important thing from the exam point of view, I want you to read about various stages of ECG changes of myocarditis. So where are you going to read? It is well written in Brownwall textbook. So this is a girl child of 5 years who presented with chest pain and dyspnea and edema feet, and we diagnosed this as a myocarditis. Very good, 4 stages. You can see here there is a stage 1, again low voltages. Here you can see the low voltages here in the pericardial, and you can see there is a ST elevation is seen here. So I will show you only some of the stages. ST elevation is seen. This is the acute stage of myocarditis where you can see the ST elevation with a typical of pericardial strain pattern rather than ischemic pattern. So next to 24 to 48 hours, the ST segment elevation disappeared, and you can see more or less electrical stage here. ECG low voltage is becoming a little bit obvious here. The ST elevation is becoming isoelectric, and subsequently T wave started actually inverting, and finally you all can see that the T waves are inverted. So I request you to read various stages of ECG stages in case of myocarditis. So you will see the sinus tachycardia, decreased voltages, and echo will give some kind of important clues. So the virus and various things you can read in the textbooks. We will go to the next case scenario. So you have a case here, a child with 120 pulse rate, regular, and blood pressure of 80/50, affects LV and other things. So this child actually came from Maharashtra. The slide is missing. This child came with chest pain. This is a 1.5 years baby, came with some kind of respiratory distress, unexplained cry, pursiness, and there is excessive crying and irritability after feeds. 1 year 2 months baby after feeds. We examined the child. The heart rate is 120, BP 80/50, and there is an S3 and no murmur. So we presume that that may be chest pain, and you can see that retrospectively we presumed. I am not telling that it is actually chest pain. So already Dr. Vimala guessed the diagnosis. I appreciate her, and you can see that cardiomegaly is there and vascularity is normal. So cardiomegaly with normal vascularity you will see in case of either myocarditis or myocardial ischemia or valvular regurgitation, or it may be due to something like pericardial effect. Myocardial, the cardiomegaly with increased vascularity, you will see various conditions like left right shunts or increased pulmonary blood flow situation. So you can see the ECG here. Again, there is a abnormality. You can see that various changes you can see in 2-3 AVM, and not clearly seen in the lateral lead. This is consistent with alpha. This is another ECG of a different baby, but that baby actually presented at 3 months of age group. You can see the ST elevation in the lateral lead suggestive of alpha here. So this is the echocardiogram, which is still picture of that alpha. So I am telling alpha may not present with the chest pain because they present very early in life. They don't present in adults. So adolescent, those who escape and well collateralized cases, they may present in the late childhood, adolescents and adults. They will have exercise intolerance, dyspnea and occasional chest pain. So we are not talking about those cases. Infants sometimes will have LV dilatation and there is excessive irritability and other things will be there. So this is another adult patient actually. They came for evaluation. She used to get a chest pain. She used to get a chest pain whenever she is playing table tennis. So this is the transthoracic echocardiogram and this is the transesophageal echocardiogram. Can you see the transthoracic echocardiogram here? Here, this is the right coronary artery actually arising from the left coronary artery and going here. So why they develop the chest pain? What is that you are telling? I don't understand. So there is a right coronary artery which is arising from the left coronary artery, traveling between aorta and pulmonary artery. What will happen during exercise is to maintain the cardiac output. The normal Oh, that's not playing. Okay. Okay, I can't help on that, but what I am showing the picture is here the right coronary artery arising from the left coronary artery going between pulmonary artery and aorta. This is an adult patient came with chest pain and referred to us actually, and adult means it's around 30 years and all. So what will happen during exercise? There will be, to maintain the cardiac output, the vessels will be dilated. Aorta to take the cardiac output, pulmonary artery to take the cardiac output will be dilated. The coronary artery will be compressed in between that. So this patient successfully underwent surgery, and the right coronary artery was given remus graft to her. So remember that these are the important cases. So I am going to tell you very interesting case now. This is a 14 years old girl presented to ER. This is a 4 years back story when I was in some other hospital. Presented to ER with severe chest pain. On examination there is a tachycardia, low blood pressure, there is a S3 and respiratory system is clear. This is the ECG. Can you see this ECG at least? Can you see the ECG and what is your diagnosis? I want to know the diagnosis, what the ECG. So that's incomplete answer. What you have written, ST elevation is an incomplete answer. So probably postgraduates from adult side, they can easily answer that. Whereas pediatric cardiologists probably bit difficult, but at least I appreciate your partial answer. There is an ST elevation where? Where is seen in ST elevation? So this is absolutely correct. You can see that ST elevation is seen in 2-3 AVF. So this is a significant ST elevation in 2-3 AVF to suggest that she is having inferior myocardial infarction. So this is an absolutely inferior MI and acute inferior MI. So how do you evaluate this? Whether it is true inferior MI or you don't know, sometimes there may be various mechanisms like Myocarditis, usually you will see most of the leads, or repolarization abnormalities, usually you will see in the pericardial leads, especially V1, V2, V3. So this is clear-cut inferior MI and you have to do property test, so which is positive. Actually, historically, what happened, this girl, I did not tell you that story intentionally, this girl underwent coil closure of coronary AV fistula. Right coronary AV fistula. This is her picture. You can see right coronary AV fistula, coil closure was there. This is the coil closure picture. We have done coil closure and we lost the follow-up of that child and came back with acute inferior wall MI. So how do you follow these children who underwent closure of the coronary AV fistula? You have to give lifelong oral antiplatelet medication. Because coronary AV fistula, you may treat the coronary AV fistula, proximal segment may be ectatic, aneurysmal and dilated. So which is the nidus and the stagnation for the blood and which may cause thromboembolism in the coronary artery. So this child we gave urokinase, and then we have done the coronary angiogram which became normal. There was no any thrombus which was. So she improved very well and we restarted oral antiplatelet medication in her situation. So the essential story is to tell you that coronary AV fistula, even you close that, we have to give oral antiplatelets for lifelong. So in the approach of chest pain, you should know what kind of chest pain, whether it is vague or associated with any posture or inspiration or after carrying books in children, and most of the children below the 7 years of age group which is not reliable, and we have to see the precipitating factors like exertion, eating, whether any other trauma, emotional stress and all. Associated symptoms like fever, whether cough is there in case of pleurisy, and any other syncope. I forget to tell you that palpitations or arrhythmias also can cause the chest pain because of the diastolic period is very shortened in case of a tachyarrhythmia. So diastole is very important for coronary perfusion. If you have short diastole because of the tachycardia, coronary perfusion will be very less. So they may get a chest pain periodically. And it is true also, we will see a lot of children, they tell that pounding of neck and chest pain and palpitation suggestive of arrhythmia. General appearance, body headed in case of Marfan syndromes or myocardial flash, vital signs and chest wall palpation, whether it is localized tenderness is there or not. Auscultation in case of S3 or any other valvular diseases and other things are very, very important in case of approach to the echocardiogram. Further evaluation includes chest X-ray whenever there is a need, like when you want to see the pericardial effusion, ECG to see the myocarditis, and sometimes arrhythmias, episodic arrhythmias may be picked up only during Holter management, and echocardiogram will give some amount of clues only in certain diseases like LVH, hypertrophic cardiomyopathy. Sometimes therapeutic trial like MVP chest pain, constantly they come to your OPD and you try medications like a beta blocker, metoprolol, they may get some kind of a relief. So I want to take this opportunity to tell you that symptom usually it is associated with non-cardiac chest pain. Most of the times important causes like aortic stenosis and hypertrophic cardiomyopathy and coronary, which is traveling between aorta and pulmonary artery, anomalous course should be picked up. That can come only when you are really aware of these situations. Thank you very much. If there is any points which I did not discuss, please communicate to me. I am happy to learn as well as reply to your queries. So